Welcome everyone to the webinar titled Now is the Time to Choose Wisely, Advancing Quality Improvement in Primary Care. Just for some housekeeping features, as you can see at the bar at the below, if you scroll down, you'll see a Q&A icon where you can put in your questions, and then there's a chat icon as well where you can put any discussion features in there as well. Make sure that your discussion is going to all panelists and all attendees if that's what you intend to do. And then during the webinar, there will be some poll questions that will come up on your screen that you can answer. They're going to be multiple choice and you can answer those as well. Other than that, I think that is all for the housekeeping, and this webinar will be recorded and the recording and slides will be sent out after just a few business days, and you'll get an email with them all. And I'll start off with some introductions with our panelists here. We're lucky to have Dr. Kimberly Wintemute, who is one of the two primary care co-leads for Choosing Wisely Canada. She served as the medical director of North York Family Health Team from 2008 to 2016. Kimberly works closely with allied health professionals to promote practice to full scope for all providers. She promotes quality improvement activities throughout her team, relying regularly on electronic primary care data as a guide for decision making. She is deeply concerned about environmental sustainability and is a fellow of the Centre of Sustainable Health Systems with Dalla Lana School of Public Health at the University of Toronto. And our second panelist is Dr. Peter Cooling, who is an assistant professor at Family Medicine, University of Ottawa. He works with the Ottawa Hospital Academic Family Health Team, where he has served as both the lead physician and unit director. Peter is a strong advocate for family medicine as a critical component of healthcare in both Canada and abroad. He is currently the chair of Choosing Wisely Canada Family Medicine Group and the co-chair of Practicing Wisely Planning Committee. And with that, I will hand it over to Peter to get us started.
Welcome everybody, and it's great to have some conversations about quality improvement in primary care, and especially in this time of COVID. I think it's very timely, and it's brought a lot of factors to bear, and I think both on the patient side and on the physician side. And I hope we have some great conversations. It's wonderful to be here with Kimberly. Kimberly and I have both worked with family health teams. We were here from the inception of our team was the 7th, and I don't know, Kimberly, yours probably was before that. And we have struggled within our team to get quality improvement front and center. We both have that passion, and I hope we can instill some of that passion with you today. So let's go to the next slide. Sorry, I'm not controlling the slides. These are our conflicts. You can see that I have some other organizations that pay some honorarium and expenses, but there are no drug companies there. So these are all groups that you should recognize. Maybe somebody that is not in Ontario doesn't recognize MUMS Guidelines. Well, MUMS Guidelines put out these, the orange books on antibiotics and pain. Again, no drug influence there. So I think I'm pretty clear. Kimberly's pretty clear as well. She works with Choosing Wisely and also is one of my colleagues presenting the Practicing Wisely course for the Ontario College. Next, so our objectives. Our objectives are quite clearly to deepen your familiarity with Choosing Wisely Canada. In these special times where we are all trying to be safe and careful, and I think patients are starting to appreciate that less is more. The other objective is to discover that for physicians, one QI project can be counted in a number of different spheres, and Kimberly is going to take us through that so that you don't have to redo it each time. You can make use of it multiple times for different requirements. Choosing Wisely is very well situated for QI within interdisciplinary teams like family health teams. We have toolkits. We've made it easy. And you just have to look at one of the toolkits and say, yes, that resonates with us and we want to do that one. Next slide. Are we going to do the poll questions? All right. Let's, Sandeep, I think, is going to launch the poll questions and we'll discuss them later. So away you go on the poll questions.
Yep, on your screen, you'll see the first poll question of has your team implemented a Choosing Wisely Canada recommendation in the past? And I'll give it a few seconds before I close it off. Okay.
So that's interesting. It looks like about 25% of respondents are aware that they have implemented a Choosing Wisely recommendation and about 42% not sure. Okay, should we go to the next one, Sandy?
Yep. Okay. And the next one is for physicians. Is participation in QI optional for your team, on your teams? Okay, and I will close that one off as well. You can see the results.
So kind of split.
Yep. And should I do the last one as well?
Yes, please.
Okay. You'll see the last poll on your screen now as well, if there's some non-evidence-based practices that have fallen away in the past year, and if you would prefer not to reinstate them post-COVID-19. And then you can put any of your suggestions within the chat, and we'll come back to them at the end of the webinar during the Q&A portion. Okay, so we have 17% yes, 13% no, and 70% I don't know. For the, sorry.
Go ahead, Sandeep.
I was just gonna say the 17% that said yes, if you could let us know of your suggestions in the chat, that would be great as well.
Great. So we have lots to discuss. All right, so we'll come back to those. We just want to give you a little background on Choosing Wisely Canada for those that are not aware. Choosing Wisely Canada is a national voice for unnecessary tests, reducing unnecessary tests and treatments in healthcare. It started in 2014, and the first, it has grown, and Choosing Wisely Canada, there is an international presence as well. I've had 2 sabbaticals where I've worked with Australia and New Zealand, and they're Choosing Wisely, and in the Netherlands. So it's an interesting movement, but by and large, internationally, Canada has the strongest one, with most of our professional societies already signed up, many recommendations. We cover all the provinces, the medical schools. We have public awareness campaigns and public campaigns, and we have over 440 QI projects ready to go for you. The funding comes from CMA, the Canadian Medical Association, and Health Canada, and so there should be no conflicts there. Those are both non-influenced by drug companies and the sort. So, COVID and resource stewardship. I think we will have some great discussion, but certainly in my practice, and I'm sure in Kimberly's, we are seeing that patients are more accepting of, not doing certain things or coming in for more minor ailments and getting some advice and really wanting to restrict their activity and cocoon and protect themselves during COVID. This is perfect timing because I think your patients are sensitized to all the fundamental things of resource stewardship that we want to advocate for. Next. So here are three of the priority recommendations for Choosing Wisely Canada. And these are quite adaptable to QI projects. They're easily adaptable to QI projects in many aspects. And these are the ones that we are really quite enthused about at present. The cold standard, which has to do with not using antibiotics for viral infections. An ongoing issue for all of us. And there are many tiers and aspects to this, but certainly the cold standard will give you some tools to use with that end in mind, that you use antibiotics appropriately. It's well thought out. It's been run through a number of panels. We've all reviewed it. I've been on the committee and Kimberly has, and we've reviewed many aspects of it. And this should be applicable in all places in Canada. Using blood wisely, this is more tailored for the hospital environment, obviously. And it is a great project if you have a small community hospital, or you're a hospitalist on a ward in a larger hospital. And again, well thought out, and many aspects and tiers to it, and the steps are all there for you. One of the recommendations now that we're very enthused about is Time to Talk. And this is the campaign about serious illness conversations. And this is going to be launched in 2021. Kimberly and I were just on a meeting about this last night. And again, I think will be well received by many family doctors, because we, Kimberly and I, certainly agree that the place for these conversations is in family medicine, because we know our patients and we know how to go through these conversations with patients. And I think our timing is best. I don't think this should be left for the hospital or when things deteriorate.
Okay, so I'm just going to pick things up to talk a little bit about physician QI requirements and how things have played out over time. So it was interesting on the poll that 43% of people thought that QI for physicians was optional. So I'm here to tell you today that it is no longer optional in Ontario. So here we go. In 2013, at a time when both Peter and I were FIT medical leads, Health Quality Ontario came forward with the first QI plans. And so this was the first time that healthcare organizations were required to submit a QI plan every year and to work on quality measures. Fast forward to 2019, and CPSO, our licensing body, came out with a new QI program. And so this is actually replacing the peer assessment and is actually mandatory. And then thirdly, the CFPC this year is launching something called the Professional Learning Plan, or PLP, which is a way of getting Main Pro Plus credits. So let's kind of go through these two new programs. So the CPSO program, again, started in 2019. It's described on their website as being proactive and self-directed, and it is a requirement every 5-year cycle. So it is a requirement for licensure for physicians. And it is replacing that peer audit or peer assessment, where one of the medical assessors from CPSO would come into your office and look through charts and discuss your practice. So, when you go onto the CPSO website and you look at what's required for the program, they suggest Choosing Wisely Canada recommendations as subject matter for doing this QI program. So they have a number of links to different possibilities for subject matter, and Choosing Wisely Canada is one of them. And you might know that both the CPSO and the CMPA are active supporters of Choosing Wisely Canada. And most importantly, physicians can count their family health team QI toward this requirement for CPSO. So, and obviously that requires the physician to be an active participant in the QI that's going on. But I'm here to tell you today that your FIT QI can be counted twice in terms of your participation. And so the QI through CPSO actually can result in a number of credits. So if you look down at the bottom here, so red circle, 34 or more credits. So the CPSO is also encouraging physicians when they're doing their requirements for CPSO to collect the corresponding credits from the National College. So what is going on at CFPC? So this PLP, or Physician Learning Program. So Janice Harvey is actively working on what is a really exciting program, and it is scheduled to launch this fall. And again, it facilitates practice improvement and yields lots of Main Pro Plus credits. So our National College, knows that, sitting in lectures for 18 hours at FMF, although sometimes fun and good for the networking, isn't the best way for physicians to change practice. They know that experiential learning and experiential kind of change is the way to go. And so again, when you do this, when you do your FIT QI, you can count your FIT QI toward this program as well. So once you're finished, there are actually 2 projects in a 5-year cycle for CPSO that are now required. And once you're beyond those 2, you can continue each year using your FIT QI that you're participating in order to get credits through the CFPC. So it looked like the answer to whether people had done a Choosing Wisely recommendation in their family health team. So 25% said yes and 40% said they didn't know. These are some of the toolkits that we have and inside each toolkit, there is a basic QI methodology that is described for how to implement the toolkit with ideas for how to capture patients, how to measure the problem, and process measures, outcome measures, balance measures, all the things that we measure in QI. And I'm just going to describe to you a project that we did from 2016 to 2018 across 6 family health teams, which was really a lot of fun, and we actually made a big difference. So this is my fun little graphic slide. Thank you, Joanna, for the graphics. So we had one shared idea, which was that Choosing Wisely was an idea worth spreading. We hammered out what we were going to do over 2 dinners. So, food always helps generate ideas, right? And I'll show you how we came up with our plan and how we came up with which recommendations we would implement. We had 3 lunches with lots of members of our team, because these were interdisciplinary interventions, and we implemented 4 interventions, and this was across 6 family health teams. So how did we decide what we would do? So this chart is actually on the Choosing Wisely Canada website. So if you go to the family medicine list and you scroll down, this chart is on there. And so this is how we decided. So when we made this chart, so first we listed the Choosing Wisely Canada recommendation on the left column, and which list it was from, which society, which QI pillar was represented. And then we asked kind of 2 real important questions. First of all, is this recommendation relevant for us? Yes or no? Because if no one you know, at a given site kind of has energy for the particular recommendation. It's not going to happen. So, so we talked about that. Is it relevant? And then we also talked about, is it measurable? Is it easy to measure? Is it difficult to measure? Because clearly if things are really challenging to measure or they really can't be measured, they don't make for good QI interventions, right? Because you can't measure your change. So wherever we had a yes in the relevance box and a yes in the measurement box, we figured, you know what? We've got a potential QI intervention here. And we came up with 4 that we agreed upon. And you'll see in this chart, if you grab it from the website, that I included a column on possible ways of measuring. So with links to some of our toolkits, but also just simple ways of measuring in the front end of your EMR. So, you know, searching for different diagnostic codes, searching the bill book, sometimes searching the CPPs, and then, you know, sometimes with, you know, a bit more kind of granular activity, sometimes not. So there's really ideas on kind of how to go about measuring some of these things. So I'm going to show you 3 of the interventions that we did. So the first one was from the Bye Bye PPI toolkit. So it was a toolkit for deprescribing long-term proton pump inhibitors for people who no longer have an active indication for it. And so this was our data. So you can see that over the 12-month period, this is people who were on PPIs for greater than 12 months, and this data was collected over an 18-month period. So we saw about an 18% reduction in use of long-term PPIs. So that's just taking people off their PPIs when they lacked an indication. And within that toolkit, there are some tools that you can put right into either Practice Solutions or Accuro. I recently had a question about whether there were tools in OSCAR, and I kind of searched around, couldn't find any, but if anyone knows of tools in OSCAR for implementing this, please let us know, maybe in the chat, because we have some interested people. The other one of the ones we did was Drowsy Without Feeling Lousy. So this was a toolkit for reducing inappropriate use of sedative hypnotic medications in older people. So we focused on people over the age of 65. This is clearly a patient safety, and not just a patient safety, but a community safety issue because of the increased incidence of car accidents that occur in this population. And increased falls, increased emergency room visit, increased delirium. So there's just a number of reasons why this one's important. And this is also, this intervention to decrease sedative hypnotic use has a lot of international traction as well. And CIHI has very good data on what's going on province per province for this problem. So we started in our 2nd year of our QI project, and we were able to reduce by almost 12%. And I would be interested to kind of look at the data now. I suspect we'd be doing even better now. But it took a bit to get this one started. So for this one, we had social workers. We trained our mental health workers in the 6 family health teams. We trained them to provide cognitive behavioral therapy for insomnia. So that piece took some time. The pharmacists on the teams worked with an evidence-based program for tapering the sedative hypnotic very slowly, which was using an asset from CADEN, the Canadian Deprescribing Network, and that's out of Montreal. And so, you know, this was really an interdisciplinary effort that required mental health workers, pharmacists, the physicians, the nurses, physician assistants, like everyone was on board. This is an area of change where patients need a lot of support, and very gratifying when people come off these medications. And then one of the other ones we did was based on this recommendation from the Canadian Geriatric Society. So avoid using medications known to cause hypoglycemia to achieve an A1C less than 7.5% in many adults who are over age 65, because moderate diabetic control in this population is generally better. So what we did was we searched for everyone who was 65 or older who was taking glyburide, which is really the longest acting medication in this class, and the one that is associated with emergency room visits and repeated hypoglycemia. And usually when people go to emerge with hypoglycemia from glyburide, they actually have to be admitted, because if you can correct the hypoglycemia in the short term, but the medication is so long acting that they'll usually have another episode within kind of 24 to 48 hours. So this is a cause of hospital admissions. And we did really well on this one, as you can see. This was an effort where our data managers did the searches and generated the list of patients who fell into this category. The pharmacists then went into those charts and recommended some changes. So they looked at the A1Cs, they looked at comorbidities and medication list, polypharmacy, and they made some recommendations to the docs, either just to simply stop the glyburide in some situations, or sometimes to stop it and consider replacing it with something safer. And then they messaged the docs with a recommendation, and then the docs took action. So again, something that required, kind of important members of the team really working together around this patient safety recommendation. So I would say that there were a few things that made the project a success. So one of the main ones was that the Choosing Wisely Canada recommendations and the efforts we were taking were aligned with the strategic plans of the organizations and with our QI plans. And it's like anything, it's hard for people to do new things off the side of their desk when they have a whole bunch of other responsibilities. But when you incorporate the work into, what you're doing and what you need to do, it becomes more possible. So, and what we did that year with HQO for those 2 years was we said to HQO, look, we're 6 family health teams. We want to implement these Choosing Wisely Canada recommendations, and we'd like to let our other QI measures rest so that we can focus on these ones. And HQO was completely supportive. They were excited. And they said to us, they said in that comments column in the QI plan, that last column on the right, they said, please just name the other family health teams that are also doing this, because they were excited to kind of see how our data came in as a whole. So having that all aligned was a key piece. The dialogue among the teams. So we had we had lunches that included, the pharmacists, the mental health workers, the data manager, the QIDs, some of the docs, the executive directors. And it was a lot of fun, first of all. And that dialogue was really important. We all learned from each other. So that was an important factor. And then also respecting local team culture. So, what we found when you're working with 6 family health teams, each team does things a little bit differently. And each team, as we all know, has a different complement of allied health professionals. And so that was, we agreed on what we were going to measure. So the actual, how we would measure it and what we would measure. But in terms of the change ideas and how the teams went about change, we left that up to the individual team, and that was important. And I think the project, was a 2-year project, and I think it really left this legacy among the teams, which was like, I know on my team at North York Family Health Team, we ask each other not infrequently now, are we choosing wisely? It's kind of part of the narrative of our team now. It's part of our culture. So,
Thank you.
all right. I'm going to try to, here comes your next slide.
Okay, so I think Kimberly really hit on an important cultural change within your group of physicians, whether you call it a primary care network in Alberta or a family health team in Ontario. Whenever a group of physicians work together with other health professionals and your clerks and everybody that's involved in patient care, there has to be a culture change to move towards QI projects. Fundamental to that cultural change is that the family physicians buy into this. So we have something more for you. Family physicians across the country, not all of them choose wisely, and that's not part of their culture. And if it's part of your passion and you want to expand that to your colleagues, you may want to consider setting up a Practicing Wisely course in your jurisdiction. So let's just step back. Practicing Wisely was an initiative that Kimberly and I were at the base of right at the beginning. And it is a course that was developed by family doctors at the Ontario College of Family Physicians. Since then, it has rolled out across Canada. I have been across this country helping train facilitators in different provinces, and every province in the country, with the exception of Manitoba, has within their College of Family Physicians a number of facilitators that can run this course. This course really does help physicians that are struggling with that kind of change. And we look at the evidence for certain things that we do, we assess that evidence, and then we talk about how we can actually change the culture to reduce unnecessary testing and treatment. And post-course, there is a very easy QI project for each of the participants that they have to do at different time intervals, and they actually get 21 Main Pro Plus credits. So there's the carrot of the credits. There's the cultural change with good evidence that can be facilitated locally with your group of physicians. In Ontario, the next session is coming up on March the 11th, and registration is going to open in early February. This is going to be a virtual session, so for those in Ontario, you can join. If you are in a province that I'm not sure if you're from PEI, if you can join this course, you probably could, as long as there was open registration. But look at your own colleges and try find the champions there that could lead a course like this to set up that cultural change.
It's also really fun.
It is fun. It's a whole day of fun.
It really is. And it's a really deep dive into the principles of Choosing Wisely Canada. Very gratifying course. Lots of networking goes on there. It's a lot of fun.
We did it at FMF, and we had a full house of participants. I can't remember if it was close, 25 to 30 participants from across Canada. It was a 7-hour virtual presentation for a full day. And we used up the extra hour in discussion because the folks that were participating still had questions and wanted to discuss options. So it is a very successful program. Kimberly, back to the poll questions.
Right. So I wanted to kind of get back to our poll questions. So true or false for physicians, participation in QI is optional. So that is now false. So this may be news to some of the docs, but I'm happy to bear that news today. And then there are some non-evidence-based practices that have fallen away in the past year, and I would prefer not to reinstate them post-COVID. So Joanna was going to monitor the chat and just see if people had inserted any of their ideas there. Joanna, do you want to just kind of chime in? And
I'm not seeing any ideas in the chat box, but maybe when we open the discussion.
Okay.
Kimberly, it's Sandy Pierre. I don't see any in the chat box as well. So if anybody does want to type them in, you can type it into the chat box or the Q&A. Again, it's on the black bar. Once you scroll down and you hover over it, it'll show up.
Thanks, Sandy. Certainly, I think one of the things that has fallen away in my practice is, we have some patients who are really kind of very focused on having an annual physical with you know, and they want testing, and they want, you know, they want half an hour or 45 minutes with the doctor. And that fell away pretty quickly during COVID, and was really, you know, replaced by, in most cases, a phone call just to review the evidence-based preventive care measures that they were due for, and in some cases either emailing or phoning in their blood pressure values from a home blood pressure machine, or coming into the office for a quick blood pressure and then leaving right away after. So that to me has been a real kind of liberation. And I'm hoping that the kind of falling away of the demand for the annual physical, I'm hoping that will sustain.
Kimberly, I have noticed in my practice, certainly, patients are also reluctant to go to the lab or to X-ray. They want to stay home, so the ground is ripe for a discussion about, you don't really need that blood test. How are you feeling? And let's talk about other things. And their willingness not to have certain diagnostic interventions because they want to stay in their bubble at home.
Right. Okay, I can't see the chat, but Sandeep or Joanna, is there anything in the chat?
Actually, just one comment came in. I'll read out the comment for you. It says, my only concern with this is missing things like a breast lump on a female under 30 and a skin lesion that may lead to something like melanoma.
All right. Well, I would say in particular for the breast lump in the younger patient, I would really like to invite the author of that question to come and take the Practicing Wisely course, because you know, the evidence actually tells us that screening clinical breast exam in the office does actually not change breast cancer mortality. And that is, of course, different from case finding. When a patient has something wrong, they notice a lump and that initiates a visit. That's different. But screening by doing breast exams on people who are otherwise well is actually not supported by evidence. Peter, any thoughts?
Well, I think it is about choosing wisely not to do something, but also choosing wisely when to do something. I have this conversation with my residents every day when they present a virtual conversation by telephone with a patient. And sometimes the right choosing wisely is to bring the patient in and examine them. This is not to say we don't do that. We are seeing skin lesions. People are sending us photographs. Sometimes the photographs are very excellent and very clear, and sometimes they're not. And sometimes they do require an examination. So, but I think they're always looking at ways to minimize how many times, like, are they coming into different facilities like that. So patients are willing to wait and see. And one of our best tools that we have in our toolbox is our ability to reassess in 2 weeks or 4 weeks or 6 weeks or 3 months. And patients are willing to do that. But there is a time to choose wisely, and that means bringing them in.
Yeah, I would echo that. I think that, you know, the Choosing Wisely Canada campaign, you know, it is a voice that speaks to the problem of overuse, but most importantly, the campaign is about appropriateness. So, you know, some test treatments and procedures are, you know, actually lack an indication or do not add value to patient care and are not appropriate, but some definitely are appropriate. So it's that striking that balance of what's appropriate is really kind of the work that we do.
Agreed.
I'm just going to go, we'll just go to our final slide. And so I just wanted to let everyone know that Choosing Wisely Canada has a regular webinar called Choosing Wisely Talks. It's on the first Wednesday of the month, and it's always for an hour from noon till 1 Eastern time. And coming up on February 3rd, it's called Make It Count Twice. And it's again about this issue of choosing wisely and continuing professional development, and how, you know, physicians can kind of make their efforts around QI count in multiple spheres. So if you want a little bit more on that, there's going to be also someone from the Royal College of Physicians and Surgeons Canada there. So please join us. Sandeep, there were some questions that were emailed in by the registrants before the webinar today. And so we tried to answer as many as we could in the talk, but I think there were some others.
Yep. So I have them over here. Oh, okay. So, you know, Kimberly and Peter, both of you, whoever wants to jump in, I'll read out the question. We can have a discussion. And then folks, if you have any comments as well, you can put them into the chat or the Q&A. The first question that we had typed in was how to engage physicians when the QI lead is a non-physician. I think also, I mean, Kimberly, you might be familiar with this as well, when the QIDs sometimes are the QI lead. So if it's a non-physician that's the lead, how would you suggest engaging physicians?
Yeah, so I know that family health teams are also required to have a quality improvement committee as one of the board committees. And so it's really important to have a physician on that committee. And hopefully also that's a working committee, like a bit of an operational committee, not just a governance committee. And so it's really important to have physician representation on that committee, and make sure that each year when you're setting your QI goals for your QIP, that there are, you know, 1 or 2 that the physicians can particularly kind of sink their teeth into.
And I will just add here as well, there was actually a lot of conversation around, you know, the QI committee and making it terms of reference. So if anybody's interested in any sample terms of references for family health teams, you can reach out to me as well. I'm happy to provide that. The second question
if I could just weigh in, you do need a champion that is a physician to engage the other physicians. That goes without saying. So somebody has to take this on and champion it. And if you start making decisions that affect physicians and the way they work, all of a sudden they want to be at the table. When we started our QI project many years ago, the physicians were not attending the meeting. But then the decisions were made that changed their workflow and so forth. And they realized very quickly that they better be inside the tent, not outside the tent.
Thanks, Peter. The second question we have here is, how do you encourage providers to take time out of seeing patients to participate in QI initiatives?
We just made it a compulsory Monday morning, 8:30 to 9. All residents, all staff, we blocked the time. You had to be there. And gradually that culture grew. And I think you have to designate a specific time. I don't know, Kimberly, how you did it.
Yeah, you know, and I think part of what we've done at North York Family Health Team is a lot of the measures that we've put forward actually don't involve time outside of seeing patients. They're actually integrated into our patient care. So for example, when we were doing deprescribing for PPIs, sedative hypnotics, the glyburide problem, I'm trying to think of others. We've done an end-of-life planning initiative on a fairly wide scale, for example. And those were really, they involved interventions right at the patient level. So it really just became incorporated and really didn't take much time out of seeing patients. There might have been, you know, for example, an hour of education, for example, but not kind of regular weekly time out of seeing patients. Rather, you know, maybe 1 or 2 sessions, but everything else was embedded. So.
Thank you. I remember when I used to work at a family health team, we used to have lunch and learns as well. And it would be, lunch was provided and they would come out. So we had a high uptake through that manner as well.
Food always works. Hot breakfast always bring people out.
The third question was around any comments that you have around designing QI projects to facilitate dissemination and research ethics requirements for QI.
Well, the beauty of this is QI does not have an ethics requirement. You have to get your head out of research. This is QI. This is practical. This is changing things on the ground. This is not, there is a fundamental difference between QI and research, and you don't have to get into that research ethics requirement. So don't create a barrier.
Yeah, and I would also just touch on the fact that sometimes you do QI and you have really impressive results and you think, oh my gosh, this is publishable. So you kind of, after the fact, you realize that you've got something that might be publishable. So there are ways of going about having things like that published. And depending if you're affiliated with a university site, you know, some of these requirements are site specific, so you'll want to check with your hospital or your university research ethics board. But there are some QI journals that really focus on publishing QI findings as opposed to research findings. And I think Joanna, I had asked, this was such a good question, I asked our one of our other physician leads at Choosing Wisely Canada about this. Thank you, Joanna. So Joanna just put in the chat a link to a list of journals that publish QI work so that people can be connected to those.
Thank you. And then the other question that we have here is, does Choosing Wisely have any collaborations with RISE or other OHT support partners? I think this is going to be a big piece as OHTs start to think of collaborative QIPs and collaborative QI initiatives. And even right now with the indicators that they're reporting on, a lot of them will need a lot of QI work to start getting implemented.
Yeah, so we don't have formal work going on with RISE right now, but we've been in touch with RISE. They know that we exist. And the message that we've had back from them is that the OHTs kind of are still working a little bit higher level, like at the governance level, you know, kind of working out governance structures and things like that, and aren't really ready to do kind of implementation at this point. So when they are ready for implementation, we're very interested in working with RISE. So thank you for bringing that up.
Thank you. And then the other question we have here, or any comments that you would have, comment on initiatives to taper opioids or benzos in COVID-19 era. Will we cause more harm than good? What are your thoughts around this?
Well, I am still successfully having conversations with patients, and I think the essence of both opioid and benzo deprescribing is go slow, go little steps, but go slowly. And those follow-up conversations can still happen. Undoubtedly during COVID, people's conditions change and there is a surge in mental health issues, but and you have to address that. I don't think opioids or benzos are either an answer for any of those things, but you have to address anxiety, depression, social situations, drug and alcohol abuse, you know, all those other things still come to play during the COVID era. But I still am having those conversations with my patients, and it seems to be slowly. The strategy is it's no different pre or post COVID. The strategy was to go slow and in small increments, consistently bring that down and deprescribe.
Yeah, and I would say I'm noticing that it certainly has been harder during COVID to live in what I would describe as an aspirational state. I know that I haven't been necessarily at the top of that, Maslow's hierarchy as often as usual during COVID, and most people probably haven't. And so I've noticed with people who are tapering either opioids or benzos that, one kind of measure of success or indicator of success during COVID is just maintaining the dose. Not necessarily continuing the taper. If they're having a really hard time, then what we're agreeing to do is not increase, but hold steady and try to draw on other resources. So.
Good point.
Thank you. And then our second last question here is ways to better engage and educate the patient to choose wisely. I think this is a great question, especially around the physical. Sometimes, patients are like, but we want to have a physical, and having that conversation. So if there's any materials that have been created.
Yeah, so there are some very good materials. So to touch on the full physical, or the so-called annual physical, the College of Family Physicians of Canada actually created a very good poster a couple of years back on this topic that you can post in your office. As Peter pointed out, during COVID, this is a great time to be having this conversation and to explain to people that, we're scientists. As physicians, we rely on science. And so we don't do things just because they've always been done. We do things because there's evidence that they should be done that's backed up by science. So having that conversation and, kind of just focusing in on the evidence-based maneuvers is really important. There are also, Choosing Wisely Canada has 4 questions for patients to ask their providers. And so you can actually order from Choosing Wisely Canada little tent cards or posters for your office. So you can do that on our website. Yeah.
Okay, and then our last question here is, folks would love to hear from both of you on the thoughts of the role of patients in prioritizing recommendations.
Yeah.
Go ahead, Kimberly.
Well, at Choosing Wisely Canada, we have patient representatives, and they have a strong voice in what we do. So we have for example, a weekly meeting where the whole team gets together, and that includes our patient and public representatives. And many healthcare organizations now, and probably many family health teams, also have a patient representative. And so I think it's important, and again, hopefully on the QI committees, to kind of engage those people around what is it that is important in our community, which measures are important. I think all of that also needs to be discussed. And, at the micro level, more at just kind of the clinician patient interface, let's say you have someone, for example, who's on an opioid, who's on a sedative hypnotic, who's on a long-term PPI and is 75, right? You're not going to try to tackle all of those things on one day. And so at that micro level, you're going to engage the person around, here are some safety issues. What are you ready to tackle? What makes sense to you? So there's that.
You might, as a group of physicians, consider a patient advisory council. We did that. It was very fruitful. We would engage them on many, many decisions on all aspects of our family health team. And that was an invaluable resource for us.
Yeah. And I think even as folks transition into OHTs, there's more of encouragement of patient advisory committees and more indicators on patient reported, experiences. So I think it's a great start to even start with a patient advisory committee for sure. These are all the questions that we have at the moment. If anyone else has any other questions, feel free to type them into the Q&A or chat. I will do a plug for some upcoming webinars as well from AFDO, but I just wanted to also launch a last poll, and it's just for your feedback on how the webinar went, and it will come up on your screen. So if you could just take a few seconds to fill that out, that would be great. And then the other part that I wanted to cover is also AFDO has an email list which can help you stay more informed. We have weekly emails that go out, and then a monthly QI e-bulletin that goes out as well. So when I send out these slides and the recording, you'll have the link and you can register for these and the webinars as well. Other than that, I think I'll wrap it up and give folks, a few minutes back in their day if there's no other questions. And I would like to thank Peter and Kimberly for attending and, helping facilitate this webinar